Good afternoon, good evening, and good morning to all my friends from different parts of the world. I welcome you on behalf of ACNS YNS committee for this yet another wonderful ACNS YNS webinar series, which we conduct on every second and fourth Sunday. And today, on the fourth Sunday of this month, we have an interesting webinar wherein we have our routine patron, Professor Yoko Kato, who is the president of ACNS. Society, and Professor Andrew Dubovov as our chairperson, who's the professor of neurosurgery at Federal Neurosurgical Centers, Novosibirsk, Russian Federation, and Professor Kostadin, who's the professor of neurosurgery at JK University School of Medicine, Japan, and Professor
Do you hear me now?
who's the
Yes.
president of.
Okay,
yes,
thank you
we
very
can
much.
hear you now.
Okay.
Yes. And Professor Fawad Pirzad, who is the president of Neurosurgical Society of Afghanistan, as our chief discussant. And we have two wonderful speakers, Professor Yasushi Shin as our chief guest speaker, and Dr. Amy Goel as our YNS speaker. And along with me, we have Dr. Sneha Chitra, Dr. Ben, Dr. Liu, Dr. Samir, and Dr. Kapil as the co-moderator for this today's webinar. So without any delay, I would request Professor Yoko Kato to say a few opening remarks, followed by Professor Dubovov, some encouraging words for the young neurosurgeon, and then I would request Dr. Sneha to introduce our guest speaker, and then we'll start the webinar. Professor Yoko Kato, could you please say a few words?
Hi, good evening, everybody. Thank you very much for joining today. So I'm very much exciting because Dr. Shin is one of my good friends, and he is an excellent neurosurgeon. He can do everything, vascular, tumor, and also the spine. And also that he is very much interested in minimally invasive treatments. So I'm very much welcome your speech, and also Amy, thank you very much for joining today. So also I'm very much excited. Your INPH maybe the shunt, your result is very much exciting to listen. Thank you very much. So we can start.
Thank you very much.
It's an honor to welcome Professor Yasushi Shin to our webinar today. Thank you very much for taking time off amidst your busy schedule. We're fortunate to hear you today, sir. Professor Shin is a Vice Director, Department of Neurosurgery, Osaka Police Hospital, Osaka, Japan. And he's going to be talking on a very relevant subject, minimally invasive spine surgery, something that is up and upcoming in almost every country. And he's going to be talking on the techniques, technologies, and clinical applications of MIS. Thank you, sir. Over to you.
Okay. Can you see?
Yes, we can.
Can you see? Hello? Yeah. Okay, can you see? Yes. Okay. Can I start?
Yes, please.
Okay. Hello, everyone. I'm Yasushi Shin. I'm glad to be here with you. My interest in neurosurgery, cerebral vascular surgery, bypass surgery, and minimally invasive spine surgery, keyhole spine surgery, skull and scalp. So I 2030, I went to Charité in Berlin, and I met Professor Peter Baikozzi and skull surgeon Professor Bernard George. So I learned many things in Europe, and I'm very interested in keyhole minimally invasive neurosurgery. Thanks to Professor Kato, I went to Sydney to meet Professor Charlie Teo. I had good time in Sydney. with Professor Charlie Teo. And he introduced me the famous spine surgeon. He is Professor Larhu Mob. He is a chief editor of Journal Spine Surgery. I had good time with Larhu Mob too. This is a famous his paper about PRIF, TRIF, minimally invasive spine surgery technique. Okay, can you hear me? Okay, okay. And
yes, we're hearing you.
Okay, so and I joined their surgery, and this is a ALIF, anterior approach surgery. So on the 2020, I had organized a spine meeting in Japan jointly with Asia Pacific Cervical Spine Meeting. So today, I would like to show minimally invasive spine surgery techniques and technologies and clinical applications. No COI, and there are some concept for minimally invasive spine surgery. Okay, surgical approach, and some microscope and endoscope and exoscope concept, and X-ray image guided surgeries. So now we can use hybrid operation room to integrate these modalities. So today I would like to show these techniques and the technologies and clinical applications. Okay, and so we have developing this workflow depending on the pathology. Sometimes we use this hybrid operation room for cerebrovascular surgery, skull-base surgery, and spine surgery. So I plan the surgical strategy and use intraoperative CT and fusion image and navigation use. So, and this automatic registration is a key technique. So we can easily use this real-time navigating. So, level check or the localization, And this is a case of adjacent segment pathology. And old patient is old. So we wanted to avoid another fixation. So I use a hybrid OR for keyhole approach. We can have this keyhole approach is entry point is very important. So intraoperative CT and navigation is very useful to find out the entry point. So this is a so-called Bernard-George approach. I use the retrojugular approach from here. Normally, for anterior fixation, you can use the inside internal carotid artery. But in this case, I use a retrojugular approach. This is VA surgery. So from here to the completion without fixation. Next case, this is a pyogenic spondylitis, and the patient is suffer from tetra paralysis. So I performed emergent operation with this Bernard-George approach. No, this is a I performed the anterior decompression without fixation, and nextly, the chronic stage, I perform the reconstructive surgery in hybrid OR. This is a surgery video. So this is an intraoperative CT. So I check the accuracy here, and this is an anterior approach. So now this is a pedicle screw entry point, and with navigation assistance. This is a pedicle screw from anterior to posterior, and this is a strut bone, graft bone, and penetrate the strut bone to the pedicle from anterior to posterior. So for in this kind of surgery, hybrid OR is very useful. So so to avoid the VA injury, intraoperative CT is very important. So this is penetrate the strut bone to the pedicle from anterior to posterior, and here is vertebral artery. So in this case, we didn't perform the posterior fixation. It is very so minimally invasive. So patient is weak. So and the previous method is under X-ray technique. So now this is our method is a novel method without no use X-ray, navigation guided anterior fixation. Nextly, I will show augmented reality in hybrid OR. So this is an intramedullary tumor and ependymoma case. Level here's tumor. In this case, I will show the typical microsurgery technique. So difference is here. We can, so I designed like this skin incision, and this is a AR image. It is helpful for design approach, and so microsurgery technique is very important. So sharp dissection is Kamiyama scissors, and dissection plane with high magnification, and this is vascular preservation is a very important technique. So high magnification and vascular preservation is very important. So here is preserve the microvessels and sharp dissection, and open the median sulcus, and tumor removal with high magnification. So here is a after removal we can check the vascular structure, and the suture appear, and the patient can walk. So in this case, AR image is helpful for, to design, create the appropriate surgical field. And after operation, tumor was removable. Next case, the metastatic tumor case. Patient is suffering from leg paralysis. And the patient is fragile. So we planned a minimally invasive approach with AR image in hybrid OR. So normally you use a long midline incision, but I avoid the long incision. I use a AR image like this, and interfascial dissection like this. No muscle damage, and layer to layer dissection, and creates a small surgical corridor. So I check the tumor location, anterior tip and posterior lower tip, and I confirmed this is a appropriate surgical field. So after that, I cut the dura and performed vascular surgery and tumor vessel coagulation and tumor removal en bloc fashion. This is a very small surgical corridor, but is designed surgical field with AR image. So no CS leakage. So from this keyhole and small skin incision, tumor removal completely. So we use this AR image cervical for cervical tumor and thoracic tumor and lumbar tumor. So sometimes I use a recapping technique with a bone curette. I cut here and recapping from here technique. And this case, the dumbbell tumor, I use firstly I perform the anterior approach to remove the tumor from vertebral artery, and second operation, posterior approach with endoscope. And this is another case with an exoscope. So I will show this exoscope surgery. So anterior approach is, I will show the anterior approach case. So this is an anatomical consideration is very important. So we can, this is an exoscope surgery. So we can see these membrane identification is very important. So anterior approach from fascia dissection, and this is a psoas muscle dissection. This is abdominal, we can so this is exoscope surgery, and we can identify the nerve, and now I reach the vertebral body and the ureter here. So sometimes OLIF approach is image guided, but this is a direct visualization, and endoscope use to and so anterior fixation with exoscope. Small skin incision with direct approach. Patient is very good. So so-called OLIF approach or XLIF is very very popular, but I use this direct visualization technique. So this is a ALIF concept. Next case is extradural angular lipoma rigorous case. External angiolipoma rigorous, and this is a second surgery. 10 years ago, patient operation was performed in China with this long skin incision. So I use another approach from posterolateral approach to avoid the adhesion. So I plan the approach preoperatively, and in hybrid OR, I perform the operation. This is exoscope surgery. So interfacial dissection, and to the spinal canal, and this tumor is a very bleeding tumor, angiolipoma, so bleeding. So now here is a lamina, and here is a pedicle. And now we remove of the pedicle, partial removal of the pedicle to the cervical canal. Here is a tumor, bleeding tumor here. And tumor removal to coagulate the feeding artery is important, and removal tumor unblocked fashion. So lastly, I will show full endoscopic spine surgery. Full endoscopic spine surgery represents a tool for the surgeon to provide a targeted access to spinal pathology. But there is a steep learning curve with this endoscopic spine surgery. Spatial sense is needed. So we developed a new workflow to get a real-time 3D orientation from navigation in hybrid OR. So once we enter the appropriate surgical field, we can get the clear view like this. So, but very clear view. But the approach is very important because this is pinpoint surgery. So anatomical consideration and there's a steep learning curve for this surgery. So cadaveric study is very important and preoperative simulation. So transforaminal approach, we can use this Cambin triangle. So I will show our developed technique. We can use automatic registration system in the hybrid OR. Then we can use real-time 3D navigation to guide the endoscopic with preoperative simulation. So this is the planning data and get the fusion image. And I will show the case. This case is after brief surgery, adjacent level herniation. So we have to reopen the surgery. So endoscopic surgery is very useful for this type of patient. I will show the procedure video. So we can see the target intraoperative, and we can find out the target point from the skin. And now we enter the endoscope, but this bony contact is very important. Here we can find out here and bone exposure. And now this is a superior arterial facet and bone removal and direct visualization and is important, and the removal like this. This is an entry point, and this is a superior articular facet, and this point. So navigation guided approach is very useful. So this is a case of posterior foraminotomy. So radiculopathy case. So here is a reference plane, and in this pathology, C6L7 is popular, but it is difficult to identify the level X-ray image. But hybrid OR is very useful for identify C6-7 level. So now we reach the bony contact and check the level here. So expose the bone and check the level and anatomy. So now remove lamina. So here is bone. Bone removal like this. And we can see the neural membrane over there. So we can confirm the pulsation and of neural membrane. So Japan is an aging population country, so we need this type of surgery. This is a patient, a 77 years old female, and she so spondylolisthesis, but the patient is stroke. So we perform the tailored approach for spondylolisthesis. Check the anatomy, and another case, the patient is 92 and herniation. So Japan is aging population country. We sometimes use this tailored approach like this. So there are many techniques published. This is a paper from Charité in Berlin about workflow intraoperative CT. And this is our paper, navigation-assisted full endoscopic spine surgery. So neurosurgery has recently embraced minimally invasive technique and technology. Hybrid operation rooms enable us to integrate these techniques, such as preoperative simulation, intraoperative navigation, image-guided surgery, endoscopic procedures, and the minimally invasive concepts based on the anatomy and physiology. Thank you.
Thank you, Professor. Thank you, Yasushi-Shin. Any questions for participants, from participants?
So yes, Dr. Yasushi?
Yes.
Thank you very much for the excellent lecture. Thank you very much. Just you can tell us what your opinion about the exoscope. Is it very exoscope?
Yes.
It's very useful comparing with the microscope. How do you think?
Yeah. I think is exoscope is very popular in Japan now, but I know that Professor Charlie Teo's operation. His technique is very nice endoscope microscope technique from keyhole. In Japan, more and more popular in exoscope, but I think for spine surgery is very useful exoscope, but microsurgery is better, I think.
Thank you. Thanks so much.
Yeah.
Can I
And
make
I
a
ask,
small...
do you have any preferences according to the different approaches where to use the exoscope in the endoscope, like depth of the operative field or the
Yes.
microsurgical elements that you're going to use?
Yes, yes. Yes.
Which approaches actually do you use the different devices?
Yes, depending on the surgical corridor and the surgical maneuver. So yes, for depending on the pathology and the surgical corridor. So from keyhole, but the microscope is very useful from surgical from keyhole. But endoscope is depending on the surgical field, I think.
Yes.
Any questions? Any questions from participants? Yes, Ahmad.
Can I ask another question, by the way?
Yeah.
The integration of the information between the cone beam CT and the brain lab is extremely important. So to be able to automatically integrate that, you have to put fiducials somewhere on the C-arm of the cone cone beam CT. Where do you put? Because it is rotating and sometimes it's hiding under the patient. How do you do the registration? That will be curious, because we have in GK in our operating room the newest version even of Zigo. It is the Pheno.
Yes.
And these kind of phenomena are very interesting and important.
But automatically registration is very useful. And planning data and intraoperative theta fusion. So we can very easily use navigating. I use a Zigo.
Where do you put the fiducials on the C-arm? Where do you put the fiducials, the markers for the registration?
Yes. Sometimes I use a reference frame with to the head frame, and sometimes I use a reference into the for lumbar case. Sometimes I use into the bone. And sometimes
you fix on the spine or spinous process.
Yes, spinal process. But our original way is I set the reference frame to the bedside.
Right.
Because patient don't move intraoperatively, and we can use the automatic registration system. So that is the point. That's the point. For the full endoscopic spine surgery, we use the navigation in the to find out the entry point.
Okay.
So
that is the
don't harm to patient. No, set the reference frame to the bedside. It's okay.
Right.
So
I like the paper. The Zigo is narrow sometimes, the space around. The patient isn't a pin holder for the neck, for instance, and so on. So it's like that. And here, when you are miking actually the navigation, actually anterior approaches have mobile structures in front. So that, I mean, regarding the trajectory might be misleading.
But head frame reference it's okay.
That's
I check the accuracy. So yes, that depending on the surgical maneuver and yes. Yes.
Okay.
Well,
thank you very much.
So next question from Professor Ahmad Fawad Pirzad. Please, Professor.
Okay. Thank you very much. Konnichiwa.
Konnichiwa.
Professor Yashushi-shin.
Thank you.
Konnichiwa,
Thank you.
Professor Kato. And salam and greeting to all colleagues. Thank you very much for nice presentation. It's very advanced techniques for mini invasive spine surgery. But in Afghanistan, it's a dream, and I'm talking from Afghanistan, you know. But I would like to know about your case that pyogenic spondylitis. It was the spine TB or other pyogenic causes? Because in Afghanistan, we have a lot of spine TB cases, POTS disease. And for doing bone graft and fixation, do you prefer before operation to my patients needs some antibiotics? If in the case of TB, we advise for patients anti-TB, and then we do operation for suppressing the TB. Thank you. Arigato.
Thank you.
Any questions from participants? No questions.
Well, I think Professor Atul Goyal is there. He was raising his hand and he wanted to make some point. We'd love to hear your comments, Professor Atul Goyal.
No, that was a very wonderful presentation showing the state of art of technology and using of endoscope, exoscope, microscope, navigation, and things like that. I'm just wondering whether we are, overusing this technology, whether we are cluttering the operative field with technology, whether we are prolonging the surgical time. Do you think the surgical time is prolonged with all these kind of maneuvers? How much time you take to do that tumor resection metastasis? How much time you take to remove that tumor with all the kind of operative tools that you are using?
For 5 hours, too long. I can understand you are saying. This is the Japanese fashion. Too long. Very
See, in one of my smallish articles, I have written that whether this minimal invasiveness is actually required in spine surgery or not. This is one article I had written for World Neurosurgery. And whether we are, to do to kill a small rat, we are just getting all kinds of bombs and nuclear weapons to kill a rat. So we have to actually consider whether we need all these things at that particular time, and whether we even need minimal exposure. Why we need keyhole exposure for a tumor? You see, when we are operating on a tumor, we need a wide exposure. We need to see the cord. We need to see the tumor. We need to dissect with 2 hands and in a proper plane. If we have removed some extra bone here and there, it is a state of art. It is the future. Of course, we have to learn. We have to get used to this kind of technology, and we have to, learn from what you have said. These are beautiful futuristic tools, and I hope that all the countries in Asia will be able to have those kind of tools. But more important than tools is the technique, is the philosophy, and that is what the younger people have to learn and have to adopt, and then they have to go further. Of course, what you have shown is absolutely wonderful, and I congratulate you for all the instrumentation and technology that you have shown.
Thank you very much.
Excuse me. In Afghanistan, we have only portable X-ray machine, and send some instrument for us.
No comment. You see, we have to, of course, what I have to tell you that you can do the most advanced neurosurgery in the world in Afghanistan. There is no question. You cannot say, I cannot do because I don't have exoscope. You cannot say, I cannot do this surgery because you don't have this. I have to tell you that we can do the most advanced neurosurgery with the number of patients that you are having, with the kind of experience, with the kind of repeated operations. You cannot do 1 operation a day. You have to do 6, 7, 10 operations a day. That number of operations will be more valuable than using all kinds of tools. Of course, we have to go towards that level of instrumentation, but we cannot be a prisoner of these kind of instrumentation. My complete belief is, and this is no argument or no discussion, my complete belief is that you can do the top line neurosurgery in Afghanistan with whatever instruments you are having. If you are blaming that you cannot do this operation because you do not have this instrument, it is you to be blamed. You cannot just do half-hearted neurosurgery or half-hearted spine surgery and say, I'm sorry, the patient became paraplegic because I didn't have exoscope. You cannot blame the technology for an incomplete or wrong operation. So my feeling is you don't have to worry about these things. You do whatever you are doing. At least you should have a good microscope. I think if you, in the current scenario, microscopes are available in every small or in a corner of the world. You cannot say that I do not have microscope and I do not work without, and I am working without microscope. If you do not have a microscope, then of course you should not be doing all these kind of things that are being shown on this platform. Microscope is absolutely mandatory. Maybe other things are not.
Professor Atul, thank you very much for your comments. Just I am joking with Professor Asushi about that they have a lot of instruments and we are facing with lack of instruments, but we are doing a lot of cases, and as you mentioned, we're doing a lot of neurosurgery cases, but invasive surgery, neurosurgery, and we are helping with our people. We know, thank you very much. But I just told him that we have only portable X-ray machine in OT, no navigator, no microscope, no endoscope, and no neurophysiology in the OT as well.
Yeah, I think microscope is very important. Microscope.
Arigato.
Microscope.
Thank you for all participants for their attention, and thank you, Yasushi Shin, for your brilliant lecture. Thank you so much.
Thank you very much, Professor Goel. Thank you very much.
Thank you.
Professor Goel, thank you for your comments.
Thank you.
Yes.
Thank you, Professor.
Let me introduce our next speaker. Our next speaker, young neurosurgeon, Dr. Amy Goel. She studied at University College in London. Now she's a neurosurgical resident at Queen Elizabeth Hospital in Birmingham in the United Kingdom. She is co-chair of British Neuro-Oncology Society Students and Trainees Subcommittee. And her fields of interest are very broad and cover many aspects of neurosurgery. For example, trigeminal neuralgia, shunting, glioma surgery, ICP monitoring, and others. Today, Dr. Amy Goel will present a report about shunting in idiopathic intracranial hypertension, a neurosurgical conundrum. Please, Dr. Goel. Switch on your microphone, please.
Thank you so much for that. And thank you so much, Professor Kato, Dr. Liu, and ACNS, Young Neurosurgery Committee, for this wonderful opportunity to present. I'm just going to try and share my screen. Are you able to see the screen now?
Yes, we can see.
Yes.
Okay. So my name is Amy. I'm a third-year neurosurgery trainee in Birmingham in the United Kingdom. And this presentation today is about controversies in idiopathic intracranial hypertension. I selected this topic because it is a condition that we still don't know very much about, what the surgical role in this condition is, and also the management varies so much across the world in this for this condition. So I wanted to talk about some of the controversies managing this specialty, managing this condition, and also talk about how in my department in Birmingham we approach this problem. Birmingham is one of the main research centers for IIH in the UK, with a lot of kind of guidelines that have come from Birmingham, which are being widely used now across the UK in managing this condition. So I'll initially start with an illustrative case presentation. I'll then talk a little bit about the pathophysiology and assessment of IIH and the UK consensus guidelines on the management of this condition. I'll also talk about some of the controversies surrounding whether or not we should shunt and what the issues are with this. And I'll also talk about some of the other surgical approaches for IIH, including venous sinus stenting and optic nerve sheath fenestration. So this is our case. So an 18-year-old student, morbidly obese, she was referred by the ophthalmology department with bilateral grade 4 papilledema and a very abnormal optical coherence tomography. She was referred to the emergency department with a 10 to 15 day history of headaches, intermittent visual obscurations, projectile vomiting, and double vision. On examination, she had reduced acuity, which was reduced only to finger counting. She had horizontal diplopia, but she had no other focal neurological deficits. She was initially admitted under the neurology team, where they carried out some imaging. This showed she had slit-like ventricles, she had a partially empty cella, and a CT venogram showed that she had no venous sinus thrombosis. So they carried out a lumbar puncture, which showed a very high opening pressure of 47.5 centimeters of water. She was diagnosed with fulminant IIH or vision-threatening IIH, and she was urgently referred to neurosurgery. When she was admitted under our team, we carried out a laparoscopic assisted right frontal ventriculoperitoneal shunt insertion, and these were the post-operative images. 6 days post-operatively, her acuity improved, her papilledema also improved, and she had improvement in other ophthalmological parameters. At clinic review after 6 weeks, she reported improvement in her headaches and in her vision. So this was just to illustrate a typical case that we see with idiopathic intracranial hypertension. So just talking a little bit about the pathophysiology. So this is a condition like many other disorders of CSF dynamics that we don't really understand fully. There are a lot of things that we don't understand about this, how this condition develops. So the three main kind of mechanisms that have been suggested are that there is an increased CSF production at the choroid plexus. There is reduced drainage of CSF across the arachnoid granulations, and there is increased venous sinus pressure. Now we know that this condition has a significant association with obesity. For many years, it was thought that this was purely a mechanical association, that patients who are obese have raised intrathoracic pressure, have raised venous sinus pressure, and this reduces their CSF absorption. But we know now that there is, there are things happening at a much more molecular level. There's raised inflammatory markers, and there are abnormal hormones that have been associated with the development of IIH. Also, this condition is associated with women, women of childbearing age. And again, there have been studies showing how elevation of testosterone and hormones can result in this condition. So as I mentioned, this condition is associated with obesity in over 90% of cases, and multiple hormones and markers have been found to be associated. For example, glucagon-like peptide, so drugs that target this GLP-1 and reduce the level of this peptide are shown to reduce the CSF pressure in rodents, in animal models. Also, increased androgen levels in women in are associated with the development of IIH. So there is quite a big overlap between polycystic ovarian syndrome and IIH due to abnormal testosterone levels in these patients. And further, there have been case reports in patients, in transgender patients who have undergone female to male gender reassignment, and the testosterone injections that they receive have been shown to cause an IIH type condition in these patients. So these are the key sort of imaging findings that we see in these patients. So on the top, we see papilledema. In the middle, we can see the partially empty sella. We can see flattening of the posterior orbit and protrusion of the optic nerve head, as well as tortuosity of the optic nerve. But none of these imaging features are kind of pathognomonic of IIH. They're all suggestive, but not, important in diagnosing this condition. So this was a study that was carried out in our unit a few years ago, which showed that women who had IIH, giving them this low energy diet for over a 3-month period was associated with significant weight loss, and it was significantly associated with reduced intracranial pressure, as well as improvement in their IIH symptoms, as well as reduced papilledema. So here we can see an association with reduced weight, which also reduces the intracranial pressure at various stages of the diet. Various headache parameters are also improved after this weight reduction diet. And also various ophthalmological parameters are shown to be improved following weight loss in IIH patients. So this suggests that there is a significant improvement with weight loss in IIH. So moving on to the assessment of this condition, as we know, these are the symptoms of IIH, which can be subcategorized into headache and cognitive, visual, and other symptoms. Out of these, headaches are the most frequent and bothersome symptom in this condition, with majority of patients complaining of this symptom. We use the modified Dandy criteria in diagnosing IIH. Patients should have signs and symptoms of raised ICP, including papilledema. There should be no focal neurology and no imaging that features of which suggest a mass lesion or a secondary cause for the elevated intracranial pressure. They should have an increased CSF opening pressure of more than 25. But it's important to note that obviously lumbar puncture is only a one-off measurement of intracranial pressure. There is a huge variation in this throughout the day, and also with position. But generally we use above, if they have a pressure over 30, this is quite suggestive of IIH. So in Birmingham, we use this. So this flow chart shows the assessment protocol that we use for our IIH patients. So essentially, when papilledema is identified, patients should undergo quite urgent brain imaging within 24 hours and a venography to exclude a mass lesion, to exclude venous sinus thrombosis. They should undergo lumbar puncture to look at the opening pressure. Secondary causes of raised ICP should be excluded. So all of these things that are associated with secondary intracranial hypertension should be excluded. And if these are all excluded, we can diagnose idiopathic intracranial hypertension. And we normally have 3 subcategories. Fulminant IIH is patients who have vision threatening and vision is at imminent risk, who need some urgent surgical treatment. Typical IIH is the typical in a woman of reproductive age with a high BMI. Atypical is those who don't have the typical demographic for this. So I'll next talk about the UK consensus guidelines on the management. So as we know, the management of IIH varies widely across the world. So in the UK, in Birmingham, a few years ago, we created this consensus guidelines on the management of idiopathic intracranial hypertension. And this was made in consensus with neurologists, neurosurgeons, ophthalmologists, and other physicians who are involved in managing these patients across the UK. And we created essentially a pathway of management of these patients. The first step of the management is weight loss. As we have seen, weight management is the first step in improving outcomes. If there is no immediate threat to vision, these patients are managed medically with acetazolamide and other headache treatments. The neurosurgical role is essentially only when the vision is threatened. And this requires urgent CSF diversion or other urgent surgical treatments such as optic nerve sheath fenestration. And if this is not possible to do within 24 hours, patients should have a lumbar drain put in as a temporizing measure. So in summary, the management of IIH involves, there are three principles: treat the underlying disease, protect the vision, and minimize the headache morbidity. And our role in neurosurgery is essentially not to treat the underlying disease, but we have a small role in protecting the vision when this becomes threatened. So protecting the vision, the surgical role, there are three main types of surgery we can do for this. One is CSF diversion, another one is venous sinus stenting, and optic nerve sheath fenestration. So I'll talk through all of these management strategies, but first I want to talk about shunting, because this is the commonest treatment that we adopt as neurosurgeons. But there's a huge range of, there's a lot of controversy about whether we should be shunting these patients, what type of shunting we should be doing, and what are the indications. So in the UK and in our center, vision-threatening IIH is the only indication for shunting. We don't do this, we don't shunt for just headaches or other symptoms if they don't have threatened vision. The problem with shunting that there is a high degree of complications and a high degree of revision rates, especially in this population of patients. There's also a lot of controversy whether we should use LP shunts, lumboperitoneal, or VP shunts, and what the utility is in non-vision threatening IIH. So this was another study that was done in our center a few years ago, where they were looking at, it was a retrospective review of all patients who underwent shunting, all idiopathic intracranial hypertension patients who underwent shunting over a 10-year period. And we see here that in patients with deteriorating visual field deficits, there was significant improvement in their deficit after shunting. However, patients who already had an established visual deficit, there was no significant improvement, which suggests that there's a critical time window. And once the patient has established visual loss, there's likely to be irreversible damage to the optic nerve, which we then are not able to reverse with shunting. There was also improvement in other ophthalmological parameters, such as visual obscurations and papilledema. And also there was an improvement in headache following shunting, a significant improvement in the 2-year period after shunting. But the same study also showed that headaches are actually, after shunting, headaches continue in 68% of cases at 6 months, and more than 4/5 of patients still have headaches at 2 years post-operative. And also additionally, we give patients low pressure headaches in about 28% of cases. So we have to consider really, is shunting really a solution to headaches in these patients? And also importantly, we find that shunt revision occurs in more than half of patients that undergo shunts for IIH. 30% of them require multiple revisions. So this is quite a big problem generally. Just talking a little bit about lumboperitoneal shunts. LP shunts were historically considered default for IIH because of the difficulty putting ventricular catheters in these patients with slit ventricles. But there are a lot of problems associated with LP shunts, such as cough headaches, hindbrain herniation, and in some cases, there have been reports of sudden death as well. And this problem happens because LP shunts, essentially, there is no adjustable valve, there is no anti-siphon device to control how much drainage is happening, and therefore putting people at risk of low pressure conditions. Also, LP shunts are associated with a longer hospital stay and are less cost effective. They have a 3 times higher risk of obstruction and a higher risk of revision as well. With the advent of newer technology such as neuronavigation and adjustable valves with anti-siphon devices, this has made ventricular shunts more easy in these patients, and VP shunts are actually becoming more and more popular for managing IIH. So in our unit, there was a standardized shunting protocol that was introduced earlier this year, which has significantly reduced the 30-day shunt revision rates in these patients from 22% to 6%. And this protocol was essentially developed to try and streamline IIH services, to try and reduce this variability that is happening even within our department and within the UK. So this standardized protocol involves essentially a few key changes. The first is the shunt insertion is carried out by CSF specialist neurosurgeons who are super specialists in this field. We carry out a frontal VP shunt insertion with an adjustable gravitational valve, and we use an integrated ICP monitor. We use image guidance with stealth navigation to insert the ventricular catheter to allow for more accurate insertion. The peritoneal catheter is placed using laparoscopic assistance from the general surgeons, and this is to reduce the distal catheter malplacement risk, which is quite common in these obese patients. And if shunting is not possible within 24 hours, we carry out a lumbar drain as a temporizing measure. So we have found that introducing these 5 relatively simple steps has significantly improved outcomes in these patients in our unit. We also use sort of integrated ICP monitoring using telemetric ICP sensors. And this is because we find that IIH patients often present with quite unclear headache symptoms, and we don't know whether these headaches are related to the shunt, whether they are related to their condition or other reasons. So having a telemetric ICP monitoring system means we can assess whether the problem is shunt related. And so this will prevent multiple adjustments to the valves and further issues related to this. Across the UK, most people have now adopted VP shunting for this condition, but there is a lot of variability with how these shunts are performed. So in London, where I used to work previously, they used to do a frontal catheter insertion via a parietal burr hole. In Birmingham, where I work now, they use frontal burr hole. So that, some people say it reduces the infection rates. It's more cosmetically beneficial, but approach varies quite a lot even now. So lastly, I want to talk about some of the other techniques, other surgical approaches to IIH, such as venous sinus stenting and optic nerve sheath fenestration. So optic nerve sheath fenestration, essentially, it is based on the concept that subarachnoid space of the optic nerve is continuous with the subarachnoid space of the intracranial subarachnoid space. And any elevation in pressure of the intracranial subarachnoid space also will cause pressure on the optic nerve. So this technique essentially involves creating a slit or opening in the optic nerve sheath, and this equalizes the pressure around the optic nerve and therefore improves visual symptoms in these patients. There are multiple techniques to perform this procedure. Usually it is carried out by an ophthalmologist. The issue is that we don't have any randomized control studies or any large-scale studies that look into the outcomes following this procedure. So much of our knowledge is based on small-scale retrospective analysis. But we are seeing some really good results following this technique in IIH patients. We don't perform this technique routinely in our unit, and even within the UK, only 2 centers are performing this, this procedure. Venous sinus stenting is another upcoming procedure for managing IIH. Essentially, it is based on the principle that most IIH patients have stenosis within their venous sinuses, and this is usually at the transverse sigmoid junction. And this can be internal, caused by arachnoid webs or arachnoid scarring, or it can be due to external compression from raised intracranial pressure. And this reduces the CSF absorption, causing intracranial hypertension. So it was first kind of introduced by King et al. In 1995, where they showed that elevated venous pressures were seen in the superior sagittal and transverse sinuses in IIH patients. And this is supposed to be the most specific and sensitive sign on imaging in IIH patients. There are some studies showing really good results and improvement or resolution in visual deficits at 3 months. So headaches improve in 85% of cases, papilledema, diplopia, and the mean lumbar puncture opening pressure has also been shown to be significantly reduced after this procedure, which involves putting in a catheter through the femoral vein and introducing it using interventional neuroradiology techniques to dilate the sinus. So, so again, the important question lies that what surgical strategy should we adopt for managing IIH? And there are not that many large-scale studies that compare the different surgical techniques in IIH. So these are 2 of the larger studies that I could find, larger kind of systematic reviews which I could find on the subject. So Felden et al. Showed in 2007, they compared venous stenting, they compared BP shunting, LP shunting, optical nerve sheath fenestration. And essentially they found that optical nerve sheath fenestration had the best outcomes in terms of visual improvement in these patients. Another study conducted 2 years ago showed also comparing fenestration, shunting, and stenting. They found pretty similar outcomes in terms of visual improvement, headaches in all 3 groups, but venous sinus stenting had perhaps higher levels of visual improvement and headache improvement. So again, we see that there is a lot of variability in studies. Most of our evidence comes from small-scale studies, retrospective studies, which again, there is a lot of bias. There's a lot of uncertainty with regards to what constitutes the best technique. I think the issue lies with we need some kind of more prospective, larger scale studies comparing the different approaches, and we need more training in venous sinus stent placement, as well as the optic nerve sheath fenestration. Because currently shunting is the main treatment strategy that we're using. But we can see here that other strategies may also be equally, if not more, beneficial in these patients. So in conclusion, IIH is a complex condition of hormonal and metabolic dysfunction. It is not simply a mechanical problem of increased pressure. Visual threat indicates the need for surgical management in these patients, and the visual threat needs to be detected early to prevent irreversible vision loss. A standardized protocol for IIH management improves outcomes, as we have seen in our own unit. Lumboperitoneal shunting is reducing in popularity in favor of newer technologies. And venous sinus stenting has been found to be a viable alternative to more traditional interventions especially in medically refractory IIH. And there is a need, as I said, for more interventional studies comparing outcomes of the various surgical interventions. So as we can see, there are multiple specialties involved in treating this problem. It is truly an interdisciplinary condition, which requires cooperation and discussion between various different specialties and units, essentially. So thank you very much. That's the end of my talk. I'll be happy to take any questions.
Dr. Dubov, you're muted. You'll have to unmute yourself.
Thank you,
Thank
you, Dr. Amy Goel, for your brilliant presentation. Very impressive. And any questions from participants?
Please. Yes, Dr. Sneha, please go ahead.
Let me first congratulate Amy for that really good presentation. I have a question and a comment to make. See, lumboperitoneal shunt, I would say, is still not becoming, unpopular. It's still quite popular with the advent of a programmable valve for the LP shunt as well. So we use a programmable valve in the LP shunt, and it's been working quite well. So that's number one. And number two, I wish to know your conservative management protocol. Do you use any other drugs apart from Diamox? Because recently topiramate is emerging as a drug that could be of use in IIH.
Thank you so much for your comment. And in terms of the conservative management of IIH, I think still we are using acetazolamide or Diamox quite a lot. But even so, within our neurology department, topiramate has the use of topiramate is becoming more popular in managing headaches in these patients. I think Diamox is slowly reducing in popularity as well, because they realize that patients are having a lot of side effects, and actually there is no significant improvement in headaches with Diamox. But topiramate is definitely one of the drugs that is being used quite a lot in managing headaches in these patients. Yeah.
Thank you. Actually, it's been found that it also has a component of carbonic anhydrase, anti-carbonic anhydrase activities. So it does also reduce the CSF secretion in addition to remodeling the headache mechanisms. So here, actually, in our institute, we use it as an add-on. In addition to Diamox, the patients are also put on topiramate.
Okay.
Thank you.
Thank you.
Well, if I may I?
Yes, please.
Thank you. First of all, congratulations, Amy, for that wonderful lecture. And as the discussion of topiramate came on, I'd like to add that topiramate has a side effect of weight loss. That is one of the main reasons that it came into the algorithm of treatment of IIH. And the current concept of IIH regarding I think in the coming times it will be the venous stenting, which will be the standard of procedure. And earlier the venous stenting was only required for where there is higher gradient pressure after and before the stenosis. But recently in the current neurosurgery journal, they have come out, and also the before YNS also they have come out with an article of 53 patients who underwent venous stenting for low pressure gradients as well, and all of them have improved well. So I think this will be one of the standard practices in future. And also, if I would like to ask Sneha regarding the programmable lumbar peritoneal shunt, which company do you use there in your place? Because
the Codman Hakim has a specific valve designed for LP shunt, wherein the valve alone has to be
yes, I know
with
that. I have seen that
shunt.
in plenty when I was in Japan, but I have searched and it was not available in India so far. Since you are using it, can you please give me the contact of the person.
I will text you.
Thank you very much. And congratulations, Amy, once again.
Thank you so much.
Any questions? I have one question. Sorry, who want to ask a question?
No, you go ahead, please, Professor. I'll ask the question after you.
Thank you. Amy, tell me please about kind of stents you use in cases of sinus stenting.
So actually within our unit, we are not performing venous sinus stenting at all. It is not something that has become popular as yet in our department. And also even within the UK, there are very few centers that are using venous sinus stenting. And I think there's definitely very good evidence that it improves, that it's very good treatment option for IIH. And I think it is a question of education. Neurosurgeons in the UK don't perform interventional neuroradiology procedures. This is performed purely by radiologists. So actually we don't have much input into developing this approach for IIH. But I definitely think that we should be learning these approaches and studying the outcomes to see if we can adopt this newer technology.
Thank you so much. Understand you. Thank you. Any questions, please?
Please go ahead.
Yes, please, Professor. Go ahead.
No.
Okay. So,
please go ahead. Sachin?
Yes. So I had two comments and two questions for Dr. Amy. First of all, congratulations for that wonderful presentation you had. An exemplary young neurosurgeon presentation, I must say. You covered the all spectrum of idiopathic intracranial hypertension. Just from the point of discussion, since the topic of topiramate came and correctly said by Dr. Raja that it came into the picture because of the side effect of topiramate, that topiramate causes weight loss as a side effect. But there are two side effects of topiramate which will also come along with the weight loss, and that is one is addiction and second is the renal stone. So because of that, again, it is going down. I've read few papers about that. So just wanted to add to that. Second thing about those LP shunt with the programmable wall, we found two problems, that like where to actually fit or land this wall, because we had two patients wherein this programmable wall got fractured and then it became malfunction. So maybe you can tell us, maybe Dr. Sneha can tell us about like where exactly you can put it. Is in the midline, or you break the lamina from the side, or towards the abdominal side, where exactly you can put it. The two questions for the ME was, since you were discussing about the pathophysiology, there's one thing I had just an observation, and I understand you're in third year. Maybe Professor Atul Goyal is there who can comment on that. That I've always noted whenever there is an hydrocephalus, or whenever there is a raised intracranial pressure, let's say raised intracranial pressure, no hydrocephalus, the point that ICP is more than 40, you can expect that there should be some transependymal seepage of the CSF. The CSF should look for the spaces to go somewhere if that pressure is too high. But in this spectrum of idiopathic intracranial hypertension, which is a sort of hydrocephalus, but the ventricles are not bloated, one thing. And second thing, there is no transependymal seepage of the CSF. So how do you explain that in spite of having that very high CSF pressure? One thing. And second thing, about the first case, beautifully presented by you. The patient had, I agree that patient had a fulminant idiopathic intracranial hypertension, and it was the vision of the patient which was at the risk and not primarily headache as a symptom. So why did you choose the ventriculoperitoneal shunting and not optic nerve sheath fenestration? Of course, the venous shunting is out of the question there, because patient didn't have any venous sinus obstruction. But if the patient has vision problem as a primary complaint, let's target the vision and divert the CSF over the optic nerve rather than diverting it through the ventricle. What do you think?
Thank you so much for your comments. So your first comment was about essentially, this is a condition of raised intracranial pressure, but yet we do not see transependymal flow. We do not see big ventricles. And why is this? Unfortunately, I don't have the answer to this question. I don't think it is something that we still know why we don't see big ventricles. But obviously there is some kind of imbalance in production, absorption, in pressures. And so, there's a lot that we don't understand at a metabolic level that is specific to this condition. And I don't think we really have an answer to that question. And that's why I find the condition very interesting, because it kind of, it's almost like it's just so difficult to comprehend why it happens. So perhaps some of the other speakers may have more kind of knowledge in with regards to that. The second question was about why we don't do optic nerve sheath fenestrations for patients with primarily visual symptoms. This is because I think there are two issues. The first is this technique is not very, it's not a very common technique with ophthalmology team here. We don't frequently use this approach, and it's a matter of, education. So it's not something that is commonly done in our department. The first line treatment we use for vision threatening IIH is shunts, is VP shunts. And actually we are finding very good results, good visual outcomes from just shunting alone. So I think that, obviously there is, it would be beneficial to look at more studies which show kind of compare the two directly in like a prospective study. But in terms of the outcomes that we are seeing with visual improvement, VP shunting is enough, is good enough. And it's a simple technique. It's something that, people we do shunting for so many other conditions. We know how to do it. So why not continue using a technique which is already well established and well known to neurosurgeons?
Thank you. Just one more question. Did you check the ventricular opening pressure in this particular case, and was it same like a lumbar opening pressure, or you did not check?
Do you mean at the time of shunting?
Yes.
They will have checked it during the operation, but I'm not aware actually what this result was. I did not look into that. But usually it is high pressure when we access.
Sure. Thank you. Thank you very much.
If I can just mention two small points. Thank you for the really comprehensive presentation on the subject. The first point is about why we don't have big ventricles. In the very recent times, has been launched the so-called lymphatic hypothesis, yes, which indicates that from the periarterial spices we have running actually the interstitial fluid and so on, but that is also going out from the ventricles. So ventricles will not increase like in other hydrocephalic or maybe IMPH cases. And that can be explaining why actually both parenchyma and CSF pressures are both high. And another small comment also I found about the so-called gravitational valve in the lumbar peritoneal shunts, which is a very important issue because there the overdrainage is really a serious issue. In those cases, if we just vertically the lumbar, after the lumbar placement, usually a little bit away of the midline, so it is entering well downwards, just a very small segment, and placing the valve there usually can work pretty well for balancing the overdrainage. That is one of the suggestions that can be given. After a very short segment going out into the subcutaneous layer from the place of the puncture. That is.
Thank you, Professor.
Any questions and comments? No comments, no questions. Thank you, Professor Yasushi Shin and Dr. Amy Goyle, for your good and excellent presentations. And thank you for many all new knowledges for all of us. I think that's all. And thank you for all participants for your questions, for your comments, and for attending in this beautiful webinar. Last word for Professor Kato, please.
No, Andre, so maybe the Prasad, raise hand.
Okay, thank you, Professor. Thank you. Thank you. Thank you very much, Amit. I think that's similar with your last name and Professor Atul Goel. It's a relationship, Professor Goel.
She's my daughter.
Oh, congratulations. Congratulations. Yeah. I suspect that she followed your way. Very congratulations. And thank you for your presentation. And just do you follow that the Friedman criteria for IIH? And what about the IIH with papilledema or without papilledema? Friedman criteria for IIH.
Sorry, thank you, sir. So I didn't understand your question. What was the question? Is it about papilledema, treatment for papilledema?
IIH with papilledema or IIH without papilledema?
So essentially, if there is papilledema, if there is visual threat, then in our department, we do mainly shunting, sometimes optic nerve sheath fenestration. If IIH without papilledema is very, it's a small subcategory of patients, which if there is no immediate impending threat to their vision, we manage them conservatively with medical treatments.
Any question for from residents? From other participants?
I would like to just ask one thing. How do your department or your unit collaborate with interventional radiologists? How do you decide whether to go for endovascular approach or for shunting?
So in our department, as I said, we don't use this venous sinus stenting as a treatment usually, but with many other neurosurgical procedures, obviously there is a lot of communication with the interventional neuroradiology department. We, for example, there is a weekly neurovascular MDT multidisciplinary team meeting that happens where we discuss like various aneurysm cases or AVM cases, and the multidisciplinary team comprises radiologists, neurosurgeons, neurologists, and other kind of specialties. And essentially, it's like a weekly meeting where we discuss what cases can be managed with interventional, what cases can be managed surgically. But unfortunately for IIH, we don't have a similar kind of, we're not yet using IR techniques.
Okay, but when the patient presents to you, you must be giving them an option of either shunting. Then it's not a fulminant type, that you either can go for shunting or you can go for a stenting. So is there any talk between your unit and the interventional radiologist? That's what means I wanted to ask, how do you decide on that?
So I think there are only 2 departments in the whole of UK that are using venous sinus stenting. And with the NHS system that we have in the UK, it really depends on whether the patient is from London or Manchester or Birmingham. If they come to our unit, we do not offer this treatment at all in our in the whole kind of region. So sometimes patients come having done a lot of research and they specifically want stenting. In those cases, sometimes we we will tell them about what we know already about our outcomes with shunting, and if they would prefer a different approach, then we would refer them out of the area to a different unit.
Okay. Thank you.
So I think thank you very much for the great speakers. And Yasushin is the good friend of mine the last 30 years. And I think the tool is too much sometimes for developing countries, but I think it's a very future, the less invasive treatment, I think, for patients. I don't know, maybe Dr. Goel will have some comments for that. But anyway, thank you very much. And also, Amy, thank you very much for a great lecture. Since some concept of the flow of the CSF has been totally changed recently. So that's why I don't know if the usual shunt is suitable, the resolution of that hypertension. And also, sometimes do you add the shunt plus the venous stenting? Sometimes do you do shunt plus shunt? Yes, please.
Thank you so much, Professor Kato, for inviting me. Again, this is really great. I'm really happy to be here. I think that I definitely, as you say, that there is a lot of research that needs to be done in this subject in the future, whether like combination treatments and stenting plus shunting, or whether shunting will become completely obsolete. We don't know as yet. In the unit where I'm working, we are not doing stenting. We just rely on shunting at the moment, but with a very strict protocol for shunting to reduce complication, to reduce obstruction rates. But yes, as you say, I think that perhaps in the future there will be, combination surgical techniques which will become more and more popular.
Thanks so much. So in the institute, the more VA shunt, because the VA shunt is maybe the best solution for the hypertension or hydrocephalus, I think. So just before the end, I want to ask Abida Shah, maybe you're the senior, the Indian lady neurosurgeon. Give some comment to her.
Amy, congratulations for this excellent presentation. And I really enjoyed it. It was like a refresher course in idiopathic intracranial hypertension. We don't see it too much in KEM. I know you're aware of that. And this was really great. And I'm proud of you.
Yes, I think so.
Thank you so much. I know all of you will be well aware about this topic already. So it was just like a refresher and learning for me as well to talk about it and to do some research into this.
Okay. So the very last is Atu Goel. Please give her some comments. Not only the subject, but anything.
No, this, you know what, at one extreme, we had Dr. Shin talking about some beautiful futuristic instrumentation and technology, which, the thing is, we should use the technology. Technology is there to use. If we are good surgeons, we can only improve if we have good technology. So you cannot ever say that I don't need technology, I can do without any technology. So technology is here to help us. Technology is here to make the surgery safe. Technology is here to make the surgery absolutely precise and clear and with minimal injury to the patient, minimum exposure, minimum skin incision, quick discharge. So there are so many things in technology, and we have to learn and we have to see how we can acquire this technology. So it was many of the things that Dr. Shin, you are doing was very informative and very educative for me, and of course for the young neurosurgeons who are watching this webinar. And as far as this subject of idiopathic intracranial hypertension is concerned, this is a subject, if you ask me one subject in which I have zero information, this is this subject. This is a very complex subject. I do see some patients here and there. And when they come, I just say, okay, just wait, don't worry, just take some drugs here and there. But I know that the headaches can be severe and there can be effect on visual system. So when the vision is in question, we have to do whatever we have to do, and we have to do in the best fashion in the current. Now, the other thing is about talking about venous stenting is an emerging technology, although the pathophysiology and pathogenesis of intracranial hypertension related to venous compression is not yet 100% clear. This is my information. The drugs are also here and there. Shunting is the only thing which has proven results, and maybe we'll learn more and more as we go further in this subject. So thank you, Amy, for giving this presentation, and I enjoyed it, and I wish we all go further in this subject and in the subject of neurosurgery.
Yes. So we look forward to the writing paper, please. Thank you. So the Sachin, please.
So thank you very much, everyone, for participating in this today's webinar. And just wanted to tell you that two information. One is our next webinar will be on the second Sunday of next month. That will be on 13th of November, same time, with some interesting topic. And we have our ACNS Congress, virtual ACNS Congress on 28th, 29th, 30th of October. So the link for the Congress will be shared on the social media. I request all of you to participate in the Congress and even encourage your young neurosurgeon to participate and learn from the Congress. Thank you very much. Thank you all the panelists, all the speakers,